Hi class, it's Dr. Smiley. This is the first audio recording for DHY 250, nitrous oxide sedation. I'm going to give you just a few little instructions so you know what to expect with the audios. I will keep them at 15 minutes or less. I find that easier to do as a speaker, and I think it's easier for you to listen to as a student, as a listener. My intent is not to read each slide to you. You can do that yourself, but to focus on certain key points that you will want to take note of in the lecture. Because the lectures or the audio is 15 minutes or less, there may be multiple audios that go with one lecture, and they'll all be posted in that particular week's Blackboard folder. So just want to mention that. Another thing I want to show you, I'm going to escape out of this full screen mode if I can, and I'm not sure that I can. I wanted to show you where speaker notes are. So I'll do that in the next recording. Here we are, Lecture 1. This week, you're covering chapters 1, 2, 3, 8, and 9. It's really the discovery of nitrous oxide, pain and anxiety management, anatomy and physiology of nitrous oxide, and now how nitrous oxide interacts with body systems. So let's go ahead and get started. Nitrous oxide is conscious sedation achieved through the inhalation of gases, two gases, nitrous oxide and oxygen. Conscious sedation, and we're very specific in saying that, is the calming or allaying of nerves, of nervous excitement, while maintaining a conscious state by either pharmacologic, drug, non-pharmacologic, or combined methods. There are three components of pain: pain perception, pain reaction, which is highly variable among people, and pain threshold or tolerance. Pain threshold or tolerance is the point at which a sensation starts to be painful and a response results. And this varies greatly from person to person. Someone with a high pain threshold has a greater than average tolerance to pain. Someone with a low pain threshold has a strong or a rapid response to a painful stimulus. When you raise a patient's pain threshold, it means a patient is less reactive to painful stimuli. Try to keep myself out of this for you. There are many factors related to pain threshold. Pain is subjective, and many factors influence pain reactions. Physical, cultural, emotional, all play a role in pain. Pain control mechanisms. I think I'll hide myself from future recordings. How do you control pain? Well, remove the painful stimulus. If you have your hand on a hot stove, you take your hand off the stove. You've removed the painful stimulus. Block pathway of pain message. That's what you're doing with local anesthesia. Prevent a pain reaction by raising the pain reaction threshold. That's what we're going to do with nitrous oxide sedation. There are behavioral methods. We call that iatrosedation. Music, meditation, tone of voice, distraction are all behavioral methods. Or depress the central nervous system. That's done in cases of course, deeper anesthesia. Dental care can use any of these, or a combination of these. Some definitions: anxiety, fear, and phobia. Right? Fear, note that it's feeling of fright or dread related to an identifiable source, whereas anxiety, the source is more vague. Phobia is an irrational fear. Nitrous oxide is not a good choice for our true phobic patients. Dental anxiety makes people avoid dental care, oral health care, which leads to poor oral health. When they go, they need more work. It becomes a negative experience, which increases their anxiety, and on and on. It can be just a never-ending cycle. The effects of fear, the effects of anxiety are physiologic, psychological, and behavioral. The physiologic effects, the fight or flight, our sympathetic nervous system comes into play. Our mouth dries up, decreased salivation, increased respiration, increased heart rate, increased blood pressure, increased glucose rate, and a decreased action in the gastrointestinal tract. So a physiologic effect. With fear or anxiety, our body actually responds. Of course, there are behavioral or psychological effects, nervous laughter, but note this one, a decreased tolerance to painful or noxious stimuli. There is a strong relationship between anxiety and pain. Anxiety lowers a person's pain tolerance. Anxiety also increases the potential for an adverse event, a dental or, I should say, medical emergency. 75% of the U.S. population reports some mild anxiety about going to the dentist. Anywhere between 6 and 20% report a more severe anxiety, causing them to avoid dental care. 40% of the U.S. population does not receive routine dental care. Fear is a major reason. You can go ahead and review this dental anxiety scale with questions to rate. If you're trying to gauge a patient's anxiety, maybe consider asking them these questions. If you had to go to the dentist tomorrow, how would you feel about it? When you're waiting for your turn in the dental chair, how do you feel? While you're waiting while the dentist gets the drill, how do you feel? When you're waiting to have your teeth cleaned, how do you feel? For our anxious patients, nitrous oxide provides anxiety relief and some pain control that's quickly reversed with minimal side effects. The drug, and it is a drug, it's easily adjusted, or we'll learn about titration to a level needed for minimal sedation. Always some definitions when you start a new course. You know what local anesthesia is. Analgesia, the diminution, reducing, or elimination of pain in a conscious patient. Sedation, partial or complete awareness of the environment, but a decrease in anxiety and restlessness. So you can be sedated and awake, completely aware of what's going on around you, but your anxiety, your fear, your restlessness is decreased. The effects of nitrous oxide, pain control, 20% nitrous oxide, delivery of 20% nitrous oxide is equivalent to 15 milligrams of morphine for pain. In fact, emergency departments will use this when an individual is suffering a heart attack, a myocardial infarction. Nitrous oxide provides sedative effects, it's relaxing, it's calming, and therefore raises our pain threshold, raises a patient's pain threshold. They are less responsive to pain. It is a conscious sedation, and just conscious sedation in general. Okay, patient is conscious. They can respond to verbal commands. All the protective reflexes are intact. Patient maintains their airway and breathes automatically. There are various levels of sedation. We'll start with anxiolysis, or minimal sedation. In this case, nitrous oxide is delivered at less than 50% level. Patient responds normally to commands. Their thinking, their coordination might be slightly impaired, but there's no impairment of cardiovascular or respiratory functions. All the protective reflexes remain intact, Again, patients responsive to commands, to verbal stimuli, as well as physical stimuli. We move to moderate sedation, so when nitrous oxide is delivered at a higher than 50% level, we consider this a drug-induced depression of consciousness. Protective reflexes are still intact, airway is intact. Again, patient is responsive to physical and verbal commands. They might need to have a few taps on the shoulder to respond. They are a little bit more sedated. Deep sedation. Patient is not easily aroused. Protective reflexes are lost or can be lost. Responsiveness is altered. A patient's ability to maintain their respiratory function is often impaired and require assistance in maintaining an open or patent airway. We need to know these, the minimal sedation, the moderate sedation, the deep sedation, because if we're going to be providing sedation for patients, patients can go from one level to the next rather rapidly, and we need to know how to manage that should they go from minimal to moderate. This shows you a nice comparison of both conscious and deep sedation. Many ways to control pain. Nothing, you could do nothing. Conscious sedation, so again, talked about iatrogenic, those non-pharmacologic ways, tone of voice, again, meditation, scent, music, local anesthesia, hypnosis, sedation with drugs, be it oral, intramuscular, IV, or inhalation. Acupuncture is another. And then, of course, a patient undergoing a general anesthesia for surgery and being unconscious. This is a chart in your book. It's terrific. I just want you to be real aware of the difference between conscious and unconscious. So we've got oral sedation. We're going to talk about this: local, oral, intramuscular, inhalation, right? Our job, what you're learning, are all, those are conscious sedations. And then past this line is unconscious sedation, or consciousness is certainly impacted. The American Society of Anesthesiologists have developed a continuum of depth of sedation: minimal, moderate, deep, and general. Minimal sedation. The sedation you are going to be delivering with nitrous oxide sedation. That's called anxiolysis, and it's nitrous oxide at a concentration of 50% or less. Moderate sedation above 50%. Deep sedation, again, recall patients in deep sedation have trouble maintaining an open airway and may need assistance with that. And then, of course, general anesthesia when surgical procedures are being performed. Again, great chart for you to check out. Let's start with the modes of sedation, different ways that you can sedate a patient. The oral mode of sedation. So if someone's going to take an oral medication, an Ativan, a Valium, long time of onset, because it has to go through the entire intestinal system, the gastrointestinal system. So up to 30 minutes. There's no way to titrate that drug. The person takes, a pill or two, whatever the dosage is. And results are, they vary really from patient to patient. In addition, the patient may need to have an escort, someone to take them home. Rectal sedatives, these aren't used much anymore, but were more often used with pediatric patients. Again, a long time of onset. Intramuscular, it's a little bit better. The drug is injected into the muscle. Time of onset 10 to 15 minutes. Intravenous, rapid onset 1 to 2 minutes. Inhalation sedation, our work, 1 to 2 minutes. I'm going to stop here. We'll pick up again.